you to the first ever virtual health webinar of the Ebenezer Seventh-day Adventist Church. Special welcome to all of you, including the presenters as well. Those of you who are joining on the Zoom platform, as well as those on the YouTube channel as well. For those of you who may not know me, I am Dr. Bentley Young. I am a resident in the Department of Internal Medicine at QH, and I'm also a member of the COVID-19 ICU medical team at the Harrison Point facility. For the year of 2021, I've been asked to serve as the Health Ministries Director at the Ebenezer Seventh-day Adventist Church, and I thought it fit in the times that we live in, for which there is a COVID-19 pandemic, that the first item of business will be to have an educational webinar for yourself and other local professionals as well here in Barbados to explain essentially what the COVID-19 vaccine is all about. And I'm sure you were aware that there are a lot of things that we're still learning about the coronavirus. And we are going to try our utmost best to explain some of the, or to remove some of the myths and to elaborate on some of the facts of the COVID-19 vaccine. And before we start, we have three presenters with us, or with me. I'm in the company of three distinguished gentlemen. I have, who will start us off with the first presentation, Dr. Edmund Blades, and I will introduce him at the appropriate time. We also have joining us Professor Simon Anderson, who is the director of the Chronic Disease Research Center here in Barbados, and as well a youth pastor that I've grown very much to like, Pastor Jason Peters, who would offer some spiritual encouragement on the matter of COVID-19 and spirit of prophecy. So before I begin, I thought it fit to share with you just a few tidbits on coronavirus in itself. And it's essentially entitled, What We Know and What We Don't Know. And so it's basically to paint a picture for you. In December of 2019, the World Health Organization received reports of cluster cases of viral pneumonia which arose in Wuhan, China. And that was in December of 2019. By the 30th of January 2020, this novel virus was determined by the World Health Organization to be a health emergency of international concern. And by March 11th of that same year, 2020, the World Health Organization declared a pandemic. And 6 years later, after the declaration of a pandemic, Barbados recorded its first 2 cases of COVID-19, for which myself and the National Isolation Facilities Manager, Dr. Corey Ford, attended to at that particular juncture. As of January 23rd, 2021, we've had globally 96,877,399 cases. There were 2 million, just over 2 million deaths reported. And the United States of America has been leading in terms of the amount or number of deaths, with 43,133,022 deaths confirmed as of January 23rd. And there were 223 territories involved. When it comes to our local statistics, as of January 23rd, there were 1,341 cases reported here in Barbados, and there were 9 deaths confirmed. We've had 622 recoveries, and we've had 710 active cases for 2021. So what do we know about the coronavirus? So at that time, initially, so what we knew then, there was very little scientific information about the virus at that particular time. And what we did know about the virus was that it was a novel RNA virus thought to be related to the bat coronavirus, and that was shown to be similar to the bat coronavirus by 96.2%. And it was initially thought to be a zoonotic illness, and the origin still remains unclear. We know, and we know now, and we've known then as well, that is spread by close contact, often by small droplets produced by coughing, sneezing, and talking. And the incubation period is around 1 to 14 days, resulting in fever, respiratory symptoms, cough, sore throat, and dyspnea as well. We initially thought that the persons of higher risk were those of the higher age bracket, particularly those 16 years and over, and it was less seen as a severe illness in the young. Peak transmission occurred in the early stages of infection, where we thought that within 2 days of developing symptoms, that was the peak at which persons would often be infectious. And cases of asymptomatic transmission were rare at the time, and the likelihood of same was being explored or unknown. There were some drugs that came out that were initially thought to be beneficial, such as hydroxychloroquine, chloroquine, and azithromycin. And remdesivir was noted to be a promising therapeutic. But an update now in terms of what we do know, it has an average incubation period of about 3 to 5 days, with the range still extending from as little as 2 days up to 14 days as well. And the symptoms, typical viral-like symptoms: fever, malaise, nasal congestion, cough, dyspnea, and we've recently found out anosmia and abusia, which is loss of smell and loss of taste respectively, are also some quite typical symptoms. We now know that asymptomatic transmission is very much possible, and that the younger patients are actually becoming quite unwell as well. We are seeing persons in their 30s and 20s who have reported cases of moderate infection of the coronavirus. So that is something that is definitely has guided our therapy and treatment protocol as well. We do know that the virus has been shown to can shed up to 10 days in multi-moderate cases, and up to 20 days in those cases who are defined as severe, which we define as persons necessitating mechanical ventilation. Then we have the newer treatment regimens that have come on board. So remdesivir and dexamethasone has been shown to be very useful in terms of reducing hospital stay, improving outcomes, and improving mortality in persons who require supplemental oxygen. And there's some others that we're still using trials, convalescent plasma, and now the vaccine, which we are going to discuss at length here in this webinar. And now we know that hydroxychloroquine, chloroquine, and azithromycin have not been shown to be useful in these cases with coronavirus. And the hot topic that seems to have everyone concerned is the mutated strains. We now know that there are quite a few of mutated strains that exist, and I'm sure we would be enlightening on this as the program or as the webinar continues. The most common, just let me highlight, is the one that everyone is talking about, the one from the UK. This is known as the B117 strain, which was isolated on December 14, 2020. So in terms of the timeline, from July 27, 2020 to November 14, 2020, Pfizer commissioned a multi-center trial involving 152 sites to look at developing the vaccine. And the initial results have revealed that it is 95% efficacious. And by December 11, 2020, the Food and Drug Administration authorized it for emergency use in persons 16 years and older. And by December 14, 2020, the first administration of the vaccine was done in the United States of America. So it leaves the questions to be answered. And this is what we're going to try to, or aim to do in this webinar. We're going to try to look at how does the vaccine work using this mRNA technology? What are the main side effects born out of the trials? Is it truly efficacious? And when does it affect the antibody response? How long do the antibodies last? And does it cover the mutated strains? So these are some of the questions that we're going to try our best to answer, bearing in mind that a lot of the information out there is still very early in terms of the trials, in terms of there's still a lot of information out there that we are uncertain about. So most of what will be presented today would be from trials and from the evidence that exists. And we will try our best to cover these questions in the coming presentation. So to start the presentations off, I have with us, well, we have with us Dr. Edmund Blades. Dr. Blades is a consultant microbiologist at the Queen Elizabeth Hospital. He acquired his PhD in microbiology from UWI for his work on the thesis and an aerobiological survey of Barbados. In his research, he looked at the microbiology of African dust transported every year from the Sahara Desert and locally generated bacteria, pollen, and fungal spores, and their relationship to asthma in Barbados. He has considerable experience as a senior microbiology technologist and laboratory manager at the Public Health Laboratory, now called the Best Santos Public Health Laboratory. Dr. Blades is a member of the Pan-American Association of Aerobiologists, and he's a certified mold inspector and spore analyst and has current interests in indoor environmental air quality, antibiotic stewardship, and resistance, as well as biosafety and biosecurity. In 2019, the 2019 National Independence Awards, Dr. Blades was awarded the Barbados Service Star for his service to public health as a microbiologist and in particular his contribution in the research into Sahara dust. He continues to enjoy working with linkages in the public health issues and the One Health agenda. It is my great privilege and pleasure to introduce Dr. Edmund Blades. He will speak to us on the coronavirus from a microbiological perspective. So without any further ado, Dr. Edmund Blades.
Thank you very much, Dr. Young, for this opportunity to be able to be a part of this discussion. My talk is on the microbiological aspect, and I hope to provide some background so that when we get down to the vaccine discussion, that we can understand how the virus behaves and therefore the kind of response it will get. I want to thank everybody for attending, and I hope that as we go through this thing together, that we will have information and confidence, and that we will not be panicking, but by God's grace, able to manipulate and go through this thing together. So my talk is the coronavirus, a discussion from the microbiological perspective. So as a background to that, I just want to talk a little bit about organisms in general. And just to give you a placement of where viruses are, I thought I would begin with talking about other organisms. And there are 6 main groups that we can think of. The arthropods, which include things like ticks and mites and bed bugs. We have the helminths, which are like the worms, hookworm, tapeworm, those kind of intestinal worm parasites. They're protozoa, amoeba, giardia, pneumocystis. Then there's the fungi, or mold, and examples of those are aspergillus and candida and yeast. As we get coming down the list, we're getting smaller and smaller. And now we're into bacteria. We have the staphylococcus, we have TB, we have the what we classify as gram-negative and gram-positives. And lastly, in this scheme of size, are the viruses. And we have examples of those: HIV, polio, dengue, measles, and the coronavirus. So from a perspective of size, the virus is the smallest in the group, with things like ticks and bed bugs and worms that can see with the naked eye are the bigger ones. A virus is so small you can't see with the naked eye. You have to get a microscope, and even not an ordinary microscope, but sometimes an electron microscope to see a virus. So the basic biology of the virus is that they are obligate intercellular parasites. They can only live while inside a living host, for example, a bacteria, plant, or animal. And the basic structure is that they're composed of nucleic acid, either called RNA or DNA. and that's the core of the nucleus. That's the inside part. And then there's a protein capsid or coat which protects that nucleic acid. And then there are other attachments on the outside, spikes and so on, that give the virus sometimes its particular characteristics. So main point here is that they cannot live outside the body, and they rely on the host cellular machinery to produce RNA. So what they do is they overtake or take over the cell's machinery and make the cells make its own virus, so that they then continue to live and proliferate inside cells, inside the bodies. So viruses will die outside the body. They cannot survive outside a living cell, but they may survive for a short while, depending on the material, on plastic, metal, wood, steel, but they will die. And some viruses, the coronaviruses, have an additional lipid envelope, waxy envelope, which helps protect them. So the point I'm making here is that, another point I'm making is that antibiotics do not kill viruses. Many people have the idea that once they have a viral infection, they have a common cold, they need to get antibiotics. Antibiotics do not work against the viruses. Sometimes you may have an underlying or a superimposed bacterial infection, which may require antibiotics, but the virus itself does not respond to antibiotics. So the coronavirus family viruses are a large family of viruses that cause a range of illnesses, from the common cold to perhaps some more severe disease. They were first identified in the mid 1960s, and they were named after the fact that they look like a crown. They have a crown-like surface structure, and that's where they get the name from, Latin. And you may recall that in 2002, there was an outbreak of SARS, or now called SARS-1, severe acute respiratory syndrome. And then in 2012, there was another coronavirus outbreak called MERS, or Middle Eastern Respiratory Syndrome. And these two coronaviruses were what perhaps thrust them into the spotlight. And now in January 2019, we have a new strain, a novel strain of coronavirus. And the fact that this novelty is that nobody has ever seen it before, and therefore the population, people, do not have any immunity against it. They cannot protect themselves. And this word immunity is going to feature big in the vaccine fight and so on. So there is no prior immunity to this new or novel coronavirus, and that's why it has caused so much chaos and destruction and death. So the SARS outbreak was short-lived. They only had 8,096 cases and 774 deaths. MERS was 2,494 cases and 885 deaths, had a higher fatality rate. But Ebola, which is not a coronavirus, but a virus, had outbreaks from 1976, 1995, 2000, 2007, etc. And there is a much higher fatality rate of 90%. Now, as of yesterday, Dr. Young gave you some figures. Same here. There were 98,487,000 cases of coronavirus, number one, with 2 million deaths. So that's a big, big issue, a big, big far cry from the previous SARS outbreaks of SARS-1 and MERS. This one, we had no immunity to it, and it spread worldwide, became a pandemic, and now we have on our hands this massive problem. There are other coronaviruses, which I mentioned here, and L63, 229E, and OC43, and HKU1, which are still circulating, but they are not causing many problems. They are caused because of the common cold, and they are not causing any real issues like the SARS-CoV-2. So the SARS-CoV-2 virus is what they call a beta coronavirus. They're alpha and gamma. It's an envelope. Scientists classify viruses like this: envelope, single strand, positive sense. It's either an RNA or a DNA virus. This one is a single strand, enveloped, positive sense RNA virus. It's spread by human-to-human transmission by droplets or direct contact. And just to give you a little background here, measles, a virus as well, is a single strand, negative sense, envelope RNA virus. HIV and dengue are single strands, positive sense, envelope RNA viruses. And herpes, on the other hand, is a double-stranded envelope DNA virus. So you have either kinds of viruses, either DNA virus or RNA virus, and they are the single-stranded positive sense or combination of all these. So what does the SARS-CoV-2 virus look like? We said earlier on that viruses, the coronaviruses, have an inner part where they have all of the protein, what we call here the nucleocapsid protein, and they have a membrane around them which holds in the stuff. But of particular note is what they express on the outside. And in this virus, these projections here, what they call the spike protein, are the ones that give this virus its particular affinity and ability to infect human cells. It is this protein here that attaches to and ruptures, invades human cells, and then the process of replication begins. So here's a virus. It has expressed on the outside all the different antigens, and as it comes later on, you can develop tests to check for all these specific proteins. You can have the test purified and so on. So you have specific tests based on these structural proteins that detect these proteins, and if you can test for this virus in the laboratory. This picture here is just a highly magnified millions of times to show the spikes on the Earth's surface, these pretty orangey projections here, and this is the envelope and the port coat, but these spikes are what give the virus its ability to attach and infect. So I said earlier on, the spike is this picture here, elucidated by electron microscopy, that the virus is covered in these spike proteins that facilitate viral attachment, viral fusion, and entry into the host cells. They also serve as a target for the development of antibodies, for entry inhibitors, and vaccines. So the spike is pretty important when it comes to this virus. These spike proteins, one or two, bind to the host receptor cells, which is called angiotensin converter enzyme 2. And it is these two things that combine to allow the virus to gain entry into your cells. ACE2 is expressed by multiple organ systems through the body, including the lungs, the heart, kidneys, intestines, and therefore it is these areas of particular interest that signs and symptoms are exhibited. You get signs in the lung, you get intestinal issues. So it is because these areas are rich or have a lot of this AC2 enzyme, and is there that the virus targets. Upon binding, the SARS-CoV-2 virus injects its RNA into the infected cell and then commandeers and uses the host cell machinery to replicate or make itself and make these viruses. And then these virus particles, when they are released from the cells, then go on to infect new cells. And you have this peak of viremia, they call it, where there's so much virus strewn around that you get symptoms and signs of the disease. So the spike, we are told by one Antoine Roby, who is a researcher, The spike is the entry key that allows the SARS-CoV-2 virus into human cells. Again, here you see the spikes and this data attached to the host cells. So now we come to the immune response. What happens when virus of SARS-CoV-2 infect or get entry into human body? So this graph here, at the bottom you see 1 to 3, those are weeks, or you can separate the 1 into 7 days and 14 days. So when you come in contact with the virus at day 0 or day 0, where you have been exposed to somebody, a cough, a sneeze, a touch, you put your hand on your face, you've touched an object that had the virus, and the virus gains entry to your body. About day 3 to 5 is when we call it the incubation period. This stage, you have no symptoms. The virus is now building up itself, it's replicating, it's multiplying, it's getting more virus. And this stage is now asymptomatic because you have not got enough virus to cause any issues. About day 3 to 5, then you get the onset of symptoms. You get your runny nose, you get your headache, you get your fevers, etc. And then your disease process steps in. So your red line, this one here, represents your virus, your SARS-CoV-2 RNA virus. The virus peaks around day 14 in the middle of the second week, between week 1 and 2, and you get this high increase of virus, which is now circulated in your body. I will explain what happens after that, but the body mounts a response. The body is very well protected, made faithfully and wonderfully by God, and it somehow senses something is wrong, and it begins to put up a fight. And this fight is coming in the form of antibodies. The virus is called an antigen. It's an invader, it's foreign. The body does not recognize it. It doesn't want it there, it will fight. And the body responds by making antibodies. The first antibody to come out is a yellow line called the IgM antibody. And this rises almost along the same time as the virus. And you can test your blood for IgM antibodies at this point. After that, you have another antibody, IgG. You also have IgA, but IgG is more common, which arises after the IgM, this blue line, and it persists longer at higher levels than the IgM, which falls away about 3 weeks. So your lab testing is based on detecting the presence of the virus, your PCR test, looking for the virus, or your antibody test, looking for IgM antibodies in the first 3 to 5 days, or your IgG antibody coming after that and persisting longer. Your IgM test will not be adequate after 2 to 3 weeks because, as seen in the chart, the antibody level falls away, it's not detectable anymore, but the IgM antibody persists. I can use this test to do a lot of things. Monitor if people have been infected. They may not have virus now, the virus is gone, but they will have an antibody presence you can detect. So this graph shows a lot. Here's the disease point, and after that point here, you get convalescence, you get better. You have the most symptoms, but you have antibody IgG and IgA persisting in your body, which you can test for. So your signs and symptoms are usually mild to moderate upper respiratory tract illness and the common cold. Most people get this at some point in their lives. They get the common cold, they have viral illnesses. These illnesses usually last for a short time and go away. They include a fever, runny nose, headache, dry cough, a general feeling of being unwell. And there are many diseases that have these symptoms. Dengue, other viruses have fever, have feeling unwell, have headache, etc. Many patients with COVID-19, however, remain asymptomatic. You have the disease, you don't show any symptoms, you're at risk of spreading it to somebody else. But some patients, as the disease progresses, get pneumonia and they require intensive care and they require a mechanical help to breathe and so on. And they shorten the breath, malaise, muscle aches and pains, etc. The less common symptoms include sore throat, prolonged cough, diarrhea, chest pain. I hear a lot about loss of smell and taste. These are things that happen. This word here at the bottom, cytokine storm, I will not talk about in much detail, but this refers to the cytokines that are liberated when the virus invades. And these have a tremendous effect on the body, causing inflammation, causing white cells to go to the area to help fight the bacteria that come along with the virus. And this is what sometimes gives people lots of issues, this so-called cytokine storm, as it sees. So the virus, because it is found in the respiratory tract, and stool samples in the gut, can be found in stool, respiratory tract, sputums, samples, the throat, the nose, these areas. But sometimes finding the case early and educating the public about the disease will help us to control this and contain this SARS-CoV virus. So what are the diagnostic tests based on the biology of the virus? I talked earlier on about the virus itself. So the main test, the most important sensitive test, very highly specific and most accurate and reliable, is the PCR molecular test, which stands for polymerase chain reaction, that detects the viral RNA material of the virus. And this test is considered the gold standard of all tests for the virus. If you have any virus, the test will pick up the virus and multiply it in a chain reaction so that you can detect now a large amount. You may have a very small amount of virus, but because the test system replicates and multiplies that small amount, the lab can now test and look for a larger amount based on that small amount which is there. And the test is very specific. It will only detect what virus material you put. So PCR tests are developed for all kinds of things, bacteria, viruses. The key is to provide the test with a specific viral pattern and protein of what you're looking for, in this case, SARS-CoV-2, and then you will multiply that and get a reaction. Then there are antigen tests, which look for parts of the virus, not necessarily the viral DNA. You get spike proteins, you get envelope proteins, and these are rapid tests, which take about 30 minutes. The PCR test will take a couple of hours. You get the antibody test, again, which detect the antibody response to the virus. You get tests for IgM antibodies, which are short-lived antibodies, 1 to 5 days. You get tests for IgG antibodies, which appear after the IgM, about 10 to 14 days. But each type of test has its place. And the laboratory and the clinicians and those who are in charge of the virus, the disease monitoring and management, will know at what point in time to use which test for maximum benefit in terms of diagnosis, treatment, follow-up, and so on. So these tests are used within the laboratory and those in charge to figure out where we are at in the virus disease and what we should do for people who have the disease. Okay? Other tests are the antigen rapid test, the antigen, which were 3-day tests, and the other tests which rapidly detect the SARS antigens. I said earlier on, the nucleocapsid or basically spike, and then the antibody test, which look for the immune response in the body. How can we protect ourselves and others? And this is a very important slide. It comes up all the time. We tell people all the time how to avoid exposure or contact with the virus. Hands, I heard the last name, Dr. Best, speaking about hands, face, and space. Hands, hand washing, hand sanitization. Wash hands regularly with soap and water, 20 seconds. And we don't do that. We wash your hands quick to go long. Wash your hands front, back, fingernail, etc. 20 seconds. Keep an alcohol hand sanitizer around. Clean your doorknobs, your sink, your taps. Have it handy. When you get in your car, having gone to the supermarket, spray your hands. When you come from the bathroom, wash your hands. When you get to your car again, use your alcohol hand sanitizer. Do not touch your mouth, your eyes, or your face, because if there's a virus in your hand, you then transfer the virus to these raw areas where it is exposed with its membranes, and the virus will gain entry that way. Face, wear your face mask. Wear your face mask. Wear your face mask. And the face mask should cover your mouth and your nose. Not wear under your chin, on top of your head, but the face mask is the single most physical barrier to protect you and others. You and others. A cotton mask, out of all the other materials, is the best kind of material out of other materials like linen and polyester and whatnot. Cotton is the best choice of material. If you are a general person in the public, cloth masks are fine. If you are in healthcare, you need a medical mask or a respirator. Those in the public can use cloth masks. Space, physical distancing. Keep 6 feet apart from the next person. No hugging, no handshaking, no kissing. I know this is hard for some people. Even me, you would spontaneously want to reach out. But in these days, hugging, handshaking, kissing, no. Keep your physical distance. Keep your social distance so that you do not come in contact with anybody. And these 3 things are good ways to help protect you and your loved ones from contracting or being exposed to this novel coronavirus. The last method of protection is the vaccine. The vaccine is perhaps our next step to provide everybody with coverage and able to prevent the spread of COVID-19. So here comes the concept of immunity. I don't want to spend too long here either, again, but we have carefully monitored the made. When it was small, children used to run around barefoot, playing in the rain. They had hardly any clothes. They'd be outside in the yard. They had chickens in the yard. They had cows. And they were very, very hardy people. They were able to resist normal common infections. That's called the hygiene hypothesis. The more you're exposed to, the more your body can build resistance or immunity. If you live in a bubble, then anything comes and hit you. You have no protection. You've not been immunized. You've not been exposed. And therefore, resistance exhibited by a host like us to any foreign antigen, the virus, and to injury that the organism which invades may cause is what we call immunity. The body builds immunity based on experience. And we have several kinds of immunity. So anything that comes to your body is foreign, is considered an antigen. And the body will respond to it by making an antibody to fight the antigen. That's basic immunity. You get an infection, you get a response. You get a virus, and you get a response. You get mumps, and you will perhaps have a lifelong acquired immunity. And I had months at a very critical time of my life. I was very scared for other reasons. The mumps affect men, especially some ways, very important ways as well. And that's one way of getting immunity. And you can also get immunity by giving vaccines, measles, you know, chickenpox. You get vaccines which are a killed next slide. But suffice to say, before we get the vaccines, that the viruses always undergo change. They mutate. They change with time. They change because they're in the environment. Some viruses some of the mutations may disappear. Some may persist. We have examples of several mutations coming up now. The English one in South Africa, some in California. And they say at that point that these viruses, these mutations, are more infectious and therefore more easily spread. And so far, the vaccines which we have are covering these variants. We hope that they continue to do so. But recently, I heard last week that Trinidad and Tobago have a variant found in the USA. So variants are with us, they will spread, and hence we have to increase our vigilance to avoid spreading corona. So we are now in a new era of vaccines. I put the whole slide here to show that this is not new. This came out in 2018 in the Nature magazine, where it talks about other viruses, other vaccines, how vaccines have helped us over the years to eradicate measles and polio, smallpox, because they use live, are attenuated, or have killed, or inactivated pathogens to use so that the body can now stimulate and mount a response. And these vaccines have saved millions of lives. So vaccines are good things. They may have side effects. They are not 100% perfect, but by and large, the world has been saved. Many lives lost. Many improved lives in quality because of vaccines against polio, measles, chickenpox, smallpox, etc. Therefore, vaccines are not to be feared. The problem is that this one happened so fast that we have a problem with it. But this is 2018. So the mRNA vaccines were around, the mRNA technology was around. Because MERS and SARS-CoV-1 disappeared, and then there was no reason, so to speak, to mount a production that would be commercial. But the technology was there. What happened this time, they used the technology that was sitting there to fast track this vaccine. And then we have these vaccines, which are called mRNA vaccines. I'll talk about that shortly. So vaccines, the conventional ones, we talk about just now, teach our cells how to make protein. We can even teach our cells how to make an antibody to part of a protein. And these trigger the immune responses. So the major part of this virus is the spike protein, which attaches, invades the cell. If we can immobilize the spike protein, if we can somehow make it not work, if we can, nullify it, we can have some hope that the virus will not invade our cells. And that's where the mRNA messenger vaccine comes in. It targets the spike protein. So what that means is that it's a messenger RNA, ribonucleic acid, and this then travels to the cell and makes the cell make antibodies to that particular part of the virus, the spike. It does not make new cells. it makes antibodies to that, and that antibody then builds up in the body. And when the virus comes along, you have something there ready to fight it. By delivering mRNA to body cells, the viral protein is expressed and an immune response is generated against it, which is the goal of the vaccine. The vaccine does not contain any live virus. There are three main vaccines out now. I know Professor Anderson is going to talk about this shortly, but just to give a background, there are three main vaccines out, one from England, Oxford University, which is being distributed in the UK and other places, a 2-dose vaccine, 28 days apart. It can be stored at 2 degrees centigrade. It's a DNA vaccine as composed to an mRNA vaccine of both Pfizer and Moderna. These other two, because they are RNA viruses based, RNA viruses are very labile, they die quickly. You have to preserve them. So they are stored at minus 70 degrees centigrade, which is very, very cold. Because if not, it will degrade and disappear and not function. So mRNA viruses need special care to preserve them and to handle them well, as opposed to the more hardier DNA vaccine. We can talk later on about vaccine hesitancy and efficacy when it comes to the question and answer session. So the ingredients in the Pfizer vaccine are listed here. I can't read all of them for you, but it's in a nucleoside messenger RNA encoding the viral spike protein of SARS-2. That's the part that works. The other things, the fats, the lipid capsule, nanoparticles, etc., are all there to preserve and to deliver and to keep this part of the vaccine viable. And the sugars and so on, and the two vaccines from Pfizer and Moderna have similar ingredients. They are very similar. That's why they're sort of the same with their mRNA vaccines. So what is not in the vaccine? We hear many people talking about what's in it. There's no fatal tissue. There are no microchips to trace you. There are no blood products. There's no mercury. There's no egg protein. There's no latex. There's no pork products. And there are no actual COVID-19 virus cells. Vaccines that are made nowadays have to go through a very rigorous process. And I'm quite confident that with all of the checks and balances we have, that these vaccines here will be of a tremendous help in providing what we call herd immunity. If you inoculate many people, then those who don't get inoculated will have protection because the virus will not spread in everybody. So let's all do our best to make sure we play our part in providing this current pandemic, that we in Barbados can do our part to slow the process down and come back to a life of normalcy. Thank you. I await your questions at this point in time.
Well, thank you very much, Dr. Blades, for your very comprehensive presentation. I want to take this opportunity before we get to questions, just to remind our participants of the rules of the Zoom platform. We're kindly asking you to keep your mics muted to avoid any interruption and distraction from the presentation. If you do have a question, you're free to place that question in the chat, and we would acknowledge it if you have time to. We would ask the question live to the panel, and you will have a response there. In the event that we run out of time in our question and answer session, we would ask that the presenters, if they do have time, to actually respond to the questions in the chat after the presentation has been completed. we kind of ask you to respect these rules as we try to have a good business sitting here for our webinar. Now, we have a few questions, Dr. Blades. I want to start it off, and I'm quite happy that you explained in detail what the vaccine contains, the technology, the use of mRNA, and that is not the live virus. I just wanted to find out if you can just shed quickly some information on whether or not, in your opinion, the mutated strains might have some coverage in the vaccine that comes up. We are seeing some mutated strains from various places, Brazil, Japan, UK. Would you be able to speak upon whether or not there is any evidence out there to suggest that the vaccine produced by AstraZeneca, Pfizer, or Moderna may offer some coverage to the mutated strains that are out there? And then there are two questions, not particularly related to your presentation, but I believe you can be able to answer as well.
Okay. Yes, we know about the variants. There are lots of concern about the variants and whether or not the vaccine will cover them. So far as I'm hearing, the current vaccines do cover the variants, but of course this is still a work in progress, and I can only speak to what is out there. That for now, at this point in time, the vaccines do cover the variants, and therefore we have a kind of confidence that they do, and I hope that this remains so. The variants can spread quite rapidly and quickly, and I would not want to hear that as they spread and mutate more, that the vaccines don't cover them. At this point, they do, and we are comfortable with that fact. Thank you.
Great. There's one question from H. Sobers, which reads, Dr. Blades, are you able to share any ideas on how the Chinese and human vaccines differ from those main three that you mentioned, which would be the AstraZeneca, Moderna, and the Pfizer vaccine? Any information on that?
No, I have not looked at that entirely. I hope that as we get down to the vaccine session with Professor Simon, that we can have some light there. I'm not sure about that. The Chinese.
Yeah, I didn't go into all of them deeply, but I can tell you that the Chinese vaccine uses an inactivated virus. That's the vaccine platform, as opposed to the DNA based or the mRNA based. So it uses an inactivated virus, and and it's still in on the development. Yeah. Thank you.
Okay, so because we are running out of time, I am going to just entertain this last question. It was posted quite early. It asked about, do babies contact the virus? Are children susceptible to the virus? The answer to that is yes. I can speak as a physician at the isolation facility, that we have children from as young as 11 months to in their teenage years. We are grateful and we are thankful that most, if not all of these children have not suffered severe complications of the disease, as seen by our US counterparts who have reported severe illnesses in the children, particularly, for example, where they're presenting with rash and severe coughing abnormalities. But what I can say for sure is that yes, children are affected by the virus, and they can spread the virus as well. We do have cases of children having coronavirus here in Barbados. Thankfully, they all have been relatively well. So I think that unfortunately, that's all the time we have for questions for Dr. Blades, because we have to move quite swiftly on to the second presentation. I will invite Dr. Blades, if possible, if you can respond directly to the questions that are in the Zoom chat, and provide the answer to them. And where possible, we do have one question and answer session at the very end that is running 30 minutes, has been running 30 minutes, and we will try to go back to any of the questions we have missed in this first question and answer session. So thank you once again, Dr. Blaze, for your very comprehensive and informative presentation. Appreciate it a lot.
Thank you, sir. My pleasure.
Okay, so our second presenter is Professor Simon Anderson. Professor Anderson is a clinical scientist using rapidly changing patient and population data resources for research, and he leads the population health science research at the UWI, also a professor of population health sciences and cardiovascular medicine. He currently holds directorship in population health sciences and cardiovascular medicine at the George Allen Chronic Disease Research Center at the University of West Indies, Barbados. So it is with great pleasure to introduce to you Professor Simon Anderson of the George Allen Chronic Disease Research Center. He will be our main presenter on public health public policies as well as the COVID-19 vaccine. Over to you, Professor. Thank you.
The typical thing with Zoom is that once you start to share your screen, you can't find the unmute mic. So forgive me for that. I hope you're seeing my full presentation. Yes?
We are, but if you want.
Excellent. Yeah, that's fine. As long as that's, so I'll just crack on. Thank you very much. Thank you for the invitation, Dr. Young. I'm just going to give you a review of what's happened over the last year. My task was to look at public policies and some of the epidemiological relationships with COVID, and of course COVID-19, and of course to talk a little bit about the vaccine. Now, Dr. Blade has done a very good job of going into some detail, so that helps me a little bit here, and I don't have to go too far deep into some of the discussions. So I'll just proceed that the information from our disclosures are gleaned from a review of the publicly available data and papers that have been published or were gifted. I've tried as best as possible to put all links in, but I may have missed one or two. So the outline here is to look at historical perspectives, the emergence of COVID-19, synergism between COVID-19 and non-communicable diseases, and the demographic factors. That's a critical thing that island states like ours need to consider. We'll do a brief and simple look at vaccine development, some slides about whether or not the region can cut it and what are our experiences with previous infectious diseases, a few slides on the new variants and the current evidence, and of course the plan ahead is for mass vaccination and what do we need to do whilst that is being planned or it's going to be implemented. Given that this was a church presentation, I thought I might introduce you to one name. Most people might know of him as a New Testament character, but in this consideration, we're talking about a different Onesimus, a Onesimus of Boston back in the late 18th centuries. He was an enslaved West African man by a church minister, and when he was around at that time, there was a terrible smallpox epidemic that was wreaking havoc over the over Boston and actually over the United States. And his slaver Martha had was a priest or a church minister, had strong interest in science and medicine, and in discussion with Onesimus, who he noted had a smallpox scar, he was given information which he published in a London publication about the account of the smallpox inoculation in New England. And what he was told by Onesimus was that people take juice of smallpox. This is probably him writing in Onesimus's vernacular, cut skin and put in a drop. So what was noted afterwards was that only 2% of those who were inoculated in Boston died from smallpox. And you might have also heard of Edward Jenner, and he was one of the, I suppose, attributed to the birth of vaccination, again with smallpox, but he noted that milkmaids who got cowpox didn't get smallpox. And he treated a small boy with a pus from a cowpox lesion, and then he challenged him with smallpox. Wouldn't be ethically possible in these days, but the boy showed no sign of illness, and he had to be because he'd been vaccinated with the cowpox. So these are historical examples of vaccination. Human society have long been had problems with viral illnesses and have had shown some ability to help themselves. And we also have the case of poliomyelitis. Again, this is probably 1950s. Affecting a lot of children, caused by a viral illness, an enterovirus. A lot of the cases were asymptomatic, but a percentage of the cases had CNS involvement and had paralytic poliomyelitis. And there was a big development of the iron lung facilities across the USA, for example, where the 40s and 50s saw 15,000 cases per year. And of course, vaccine development through Salk and Sabin, who took quite different approaches, but successful. So we have a system of trying to prevent an infected individual from causing problems in susceptible adults, because the mode of operandi of viruses will act either through aerosolization, through droplets, through direct contact, and through transmission involving touch, computer remotes and going into trains and handling bars and etc. Those are all of the sources that is going to make a susceptible individual, a person who's become infected. So 2019, 2018, and I say 2019 because December 2019 when it all went down, but 2019 to 2020 is that been a year of precedent. Because we saw the outbreak of an unusual disease manifesting as severe pneumonia. We know then that it was caused by the SARS-CoV-2, which is a positive strand RNA virus, as shown from the previous presentation. But the disease has spread across borders, leading to global pandemic. So what we've had is a scramble to find efficacious treatment. And in the early days, that was through repurposing of known drugs or antivirals. Every one on the dog also had a remedy as well. But what happened? I'll just mention a few: chloroquine, azithromycin, remdesivir. There was also antivirals, lopinavir, and of course there was the antiparasitic drug ivermectin, and of course immunoglobulins and corticosteroids and interferon. All of these were thought to be helpful, and of course in the world of epidemiology and medicine, randomized clinical trials are what are required for advising treatment for any condition, including COVID. And so we have here just this final report from a New England Journal of Medicine paper for remdesivir for the treatment of COVID-19. The plots on the right-hand side panel just shows the difference, the cumulative number of cases over time. And what they showed from this study was that remdesivir was superior to placebo or nothing in shortening time to recovery. But of course, what we want to do is to stop mortality. But certainly, there was some evidence after some time, and this came this was published in May 2022. Dexamethasone from the recovery trial. This is a UK-based trial. They tested this in patients hospitalized with COVID, and they found that the use of dexamethasone resulted in a lower 28-day mortality among those who either received invasive mechanical ventilation or oxygen alone at randomization, but they didn't find any the same thing amongst those who were not receiving respiratory support. And finally, we have another repurpose study, repurposed antiviral drugs for COVID-19. This was the WHO Solidarity trial that was conducted across the world. And the conclusions I'll just put up here: remdesivir, hydroxychloroquine, lopinavir, and interferon regimens had little or no effect on hospitalized patients with COVID-19, as indicated by mortality. So this was another study that was that helped to look at a repurposing of drugs in the early days of the COVID experience. But this required more than just drug therapy, and the WHO did a lot in terms of a response to help with the COVID-19 situation. A lot of that required them to send out millions of items of PPEs and diagnostic medical supplies around the world, and they were able to publish documents. They had in some countries helped to set up systems for oxygen, because there were a lot of countries who did not have oxygen to treat people who would be advanced with COVID-19, and therefore this was an immense thing, particularly in Africa and in other regions, and of course training and the development of lab testing capability, was important. So, for example, at the start of COVID-19, only 2 countries had testing capabilities, and by the end by mid-year, all 54 countries in Africa had COVID-19 testing capabilities. So we basically reached at the vaccine landscape by the end of 2020, because at the time, as of 17 December, there were 166 candidate vaccines in preclinical evaluation, and 56 candidate vaccines in clinical evaluation. In other words, in clinical evaluation, a vaccine has about a 20% chance of success. It's tested for safety and efficacy in groups, having moved away from animal studies, etc., which is the preclinical aspect. In combination with that, you'll hear me talk about NPIs, or non-pharmaceutical interventions. And in the early pandemic, the NPI response was the most effective. And as we have a surge happening again, it will be the most effective again, as we wait for vaccination rollout across countries. So, for definition, non-pharmaceutical interventions are public health measures that aim to prevent or control SARS-CoV transmission in the community. And so, as long as there's no effective, safe vaccine present to protect those at risk, the NPIs are the most effective interventions that we have at present. So it has played a critical role in reducing transmission rates. It has had negative impacts. We're not saying that it is all la-di-da-di. In general, it has affected the well-being of people and the functioning of society, and it has affected the economy worldwide. Okay, but what it has done is it has allowed us to look at the most vulnerable and to have specific recommendations to protect those individuals, including enhanced surveillance or comprehensive testing or control practices in long-term care facilities. So as you will have heard recently in Barbados, where there was talk about whether or not there was community spread, community transmission, etc. The bottom line is that during community spread phase, interventions which include advising the population to voluntarily self-isolate if they've got symptoms, to work or meet in a social bubble. That in some countries that has worked, particularly families are the main bubble that you could consider. Limiting the size of indoor and outdoor gathering, promoting teleworking where possible, closing selected business where places, these are places where people have limited possibility for physical distancing. And of course, environmental measures, just cleaning frequently touched surfaces, cleaning surfaces, cleaning your hands, and having appropriate ventilation of indoor spaces. In the event of widespread transmission, so this is where the control is lost. Stay-at-home measures are a last resort, and we've seen in Europe, in the most part, that most communities are in a stay-at-home measure based on public health advice. This is typically a last resort option because of, in this targeted way, both geographically and over time, you can control outbreaks, as we've seen earlier in March and April. Population-wide testing strategies may be appropriate, but of course, you need to have tests that are efficacious and easy to be implemented. And we will also find reactive closure of schools as may be necessary because the consequence of widespread virus transmission in the community through educational settings. Everybody can undertake physical distances, can adopt strict hand hygiene, should have respiratory etiquette, and appropriate use of face mask in areas where physical distance is not possible. Stay at home if you have symptoms, and other considerations are there in this slide. So what did the Caribbean do? What did we do during all this time? Well, there are a couple of papers that have been documented, and I'll just talk to two of them. One came out of our institute. This one basically indicated that the Caribbean response to the COVID-19 outbreak was really a network of national responses, because we have, through agencies like Syndemic, etc., we are fragile to regional resources, and we are also fragile to a lot of environmental harm. And so there has been planned emergency response systems in place to deal with hurricanes, volcanoes, etc. And so it was quite easy to start mobilizing capacity through a network of response. Another thing to note from the papers was that early border controls were particularly effective amongst Caribbean islands. So here's a pictorial from this paper, and they looked at three areas: the control of movement in the country at the top left, control of movement in the country, within the country itself, and the control of gatherings. And if we use a couple of examples, say Barbados, there was no control of movement in the country, but there was control of movement in the country. And as you look through the various countries across the Caribbean and compare it with with the larger countries, and this is around the time of April 2020, you'll find that a variety of intervention, non-pharmaceutical interventions were adopted. With respect to things like curfew on the right-hand side, partial lockdowns, full lockdowns, or not implemented, a lot of the countries had curfews on board. A lot of countries, including Barbados, had a partial lockdown and full lockdown as the pandemic evolved in the early days. And this slide shows time to NPI in the Caribbean. So this was before the days before the first case. So for all of the countries, if you look at control of movement into the country, if you look at control of movement within the country and the control gatherings, you'll find that a lot of countries in the Caribbean had, for example, control movement in the country well before the first case was found for example, in Barbados, in Jamaica, etc. And then pretty soon after the first case, in the days, Caribbean countries were very quick in terms of within 20 days to control movements within the country and also to control gatherings across the board, compared to the big economic states in Europe and others. The Jamaican experience, they described theirs as a round one of the war games in the Caribbean. A very nice paper by Professor Christie. And they utilized, this is looking at it from a different perspective, but they utilized key infectious disease epidemiological practice to do control, checking case, finding all your cases, and to go back and see if there are any chains of transmission, and they were able to map it out over time to see what was going on. And this was by July 2021. Of course, when you get overwhelmed, it might be difficult to do this, but in the early days, this is what was done. So the region and through PAHO has reporting of COVID-19 data, so you could track what's happening on each island. And as you can see here across the region from March to November, the number of cases by reported and what's and by symptoms were quite reasonable in terms of numbers. This is for the whole region combined, but as November came to fore, you can see that the cases started to rise, and hence in countries like Barbados, we can show you that from the 10th of December, if you look in this third or fourth row here, the number of cases per day budging more than 100, whereas before that we were getting less, like 1 or 2 cases per day over time period. And the experience of different countries like the Bahamas, for example, or Belize or Jamaica, they had their sort of their daily cases rising significantly over 100, etc. From July onwards, places like Haiti all the way from May, Trinidad and Tobago. And so now Trinidad and Tobago's numbers per day are falling, whilst ours in Barbados are increasing. And this is a summary in terms of the total number of daily cases, the regional daily cases, and this was updated yesterday. There's about 71,000 cases and 1,500 deaths in 14 CARICOM countries, and in the 6 UK territories, there's about 1,900 cases and 20 deaths, with the first cases confirmed around March. And the final slide in this series that I'll show you is this plot of what's happened in Barbados compared to New Zealand, Iceland, Singapore, and the UK. And as you can see, we were having sort of cumulative number of cases were quite low, just above 100 all the way to December, and then of course a little bit of a bump there in terms of the cumulative number, reaching up above 1,000 cases at present. So why is this important, and what's our next step? One of the things that was noted quite early, and I will just use a quote here from Richard Horton, who is the editor of The Lancet, where he spoke of two categories of disease interacting within specific populations. You had infection with severe acute respiratory syndrome, coronavirus, and we also had an array of non-communicable diseases. And there was clustering of these conditions within social groups according to patterns of inequality that are deeply embedded in our society. So, for example, if you're in the UK or the USA and Canada, those people who are of African origin, those people who have of origins from other communities across the East, they were the ones who were having the higher cases. And the idea was that the aggregation of these diseases on a background of social and economical disparity meant that COVID was a syndemic. It was a synergy between the NCD pandemic that we're currently facing and the COVID-19 pandemic. And if you look at the syndemic for us in the Caribbean, it's obesity, diabetes, hypertension, heart disease to some extent. You know, we need therefore a different approach to protect our communities. And what I would show here is that these groups, those who are overweight, those who are smokers, frontline workers, elderly, males, and people living with NCDs were more likely to suffer from COVID-19 and to suffer from an advanced disease leading to higher rates of mortality. So people with NCDs, including cancer, for example, have increased risk of COVID-19 related mortality and a higher risk of severe COVID-19 disease. In the US, the data shows that 6-fold higher hospitalization and 12-fold higher mortality. In China, there was a report of 28% of patients with cancer and COVID died compared to a 2% death rate overall. Amongst those with diabetes, the risk of death for a severe case of COVID doubles, and of course, smoking. And when we examined the literature recently, and these were some slides that my PhD student shared with me this morning, just to get you some numbers. We know that the positive correlation between COVID and NCDs, but if you look at pre-existing conditions like diabetes, hypertension, and obesity, for type 2 diabetes, people with type 2 diabetes more likely, twice more likely, people with type 1, 3.5 times more likely to have severe COVID outcomes in terms of being iller or being or more likely to die. Other bits in the peer-reviewed literature showed that the elderly patients were more likely, they were 22% more, were more severe. There were more critical severe cases. The exacerbation amongst the obesity was greater. There was also evidence of severe sepsis observed in children who are in a PQ, which is a pediatric ICU, and respiratory illnesses were observed in patients with obesity, PQ patients with obesity. And of course, there's an increased mental health challenges among the general population due to isolation, physical distancing, and the quarantine measures. Some of which related to socio-economic deficits, including losing their jobs, etc. So what we have here are across the Americas, 325 million people at increased risk for COVID. And what we know is that those who have one or two conditions, or those who have at least one, have a higher risk of severe COVID-19 across the Americas. Other considerations in the literature, we spoke about mental health. There's a specific need for mental health care amongst practitioners. There's a drastic impact on the national economies. There's an increase in the poverty gap and a significant impact on the educational sector to the closure of schools, which is going to exacerbate inequalities in our society, and of course the impact on food security. We have a large dependence on food imports. Does prior infection prevent you from having COVID again in the future? Well, I mean, humans been asking that question much in the past, as we have been asking now. And this is from the history of the Peloponnesian War Thucydides, who in 1431 spoke of a disease that was rampaging in the air in upper Africa and in around Middle East at that time. No ostensible cause. People were in good health, were all of a sudden attacked by violence, heats, etc., etc. We think it may be any of these diseases, but we can't be certain. But one thing that he wrote was that yet it was those who had recovered from the disease that the sick and dying found most compassion. These knew what it was from experience and had no fear for themselves. For the same man was never attacked twice, never at least fatally. This is a very good description that in this case, there was immunological memory. Can we say the same for COVID? We're not sure. And why do I say that? There are a paper published here on the preprint, October 27, looking at the declining prevalence of antibody positivity in SARS-CoV-2. This was a community study of 365,000 adults. And what they showed was that antibody prevalence adjusted for test characteristics and weighted to the adult population of England declined from 6 to 4.4. And as you see on the plot on the right, over 3 months of the study. So we can't guarantee that having had COVID once before, that we are protected forever. Okay, so quick talk about vaccines and vaccine development. So for vaccines to work, we particularly in COVID-19, we have to protect against a severe acute respiratory syndrome, because that is what is mostly the cause of death. And this has been the big agenda for 2020. The important thing to understand is that any licensed vaccine should be efficacious, and it should have a good duration of protection. What we want is vaccines to protect against infection above 80%. We've seen some of these vaccines that we have nowadays talking about 95% or more. But we need to be vigilant in terms of surveillance of the number of people who are treated and the number of cases. We have to collect this information to be able to say whether or not immunity to SARS-CoV is going to be 12 to 18 months in duration, as it's been suggested, or longer. So the key things that we need to understand about the vaccines, that some of these vaccines are based on new technologies. They're based on which we can develop and produce them in a rapid way. And the vaccines only go on the market after a thorough and rigorous evaluation. And once authorized, vaccines are meant to be available to countries at the same time, and at the same conditions. But we will see. I said before, this is from the World Health Organization landscape of coronavirus candidate development. And as you see here, there are 64 in clinical development, 170 in preclinical, and the platforms are variable protein or viral vectors or DNA or inactive virus or RNA or viral vector replicating virus-like particles. There are a wide range of different kinds of vaccine in development. And in terms of the percentage, protein subunit vaccines are the most in development, the vaccines that use that type of platform. Quick slide about the comparison of the current ones in regime. We've been hearing about the Oxford AstraZeneca vaccine, the Moderna vaccine, and Pfizer Biotechnic. They are of different types. The Oxford vaccine uses a genetically modified viral vector. The Moderna and Pfizer uses the RNA codes, And we know a little bit about the Sputnik, which is the Russian vaccine, which uses a viral vector. All of these require 2 doses, and all of these have effectiveness. The Oxford one, 62 to 90%, and the other 3 above 90%. Of course, the Moderna is the most expensive, and the important thing to note is that the Pfizer vaccine requires 9-70 storage. The inactivated Sputnik vaccine from Russia is a little bit more stable because it doesn't need supercooling, and so a lot of countries in Africa and other areas who lack the capacity to sustain ultra-freezing chain as needed by the mRNA vaccines may have to go for virus vectors that are stable. So as of December 28, there are 3 large-scale phase 3 clinical trials in progress. There's an AstraZeneca vaccine, the Janssen's and Novavax vaccine. These are currently in trial. So what's going on in terms of inoculations? Per 100 people, Israel seems to be doing the best. They've vaccinated 38 per 100 people, followed by the United Arab Emirates, UK, and USA are doing well with their vaccination processes. The UK calculates that by mid-February it wants to vaccinate 50 million people, but they have multiple modules, and they would need to be vaccinating over 384,000 people a day to reach that number. Across the United States, there are 2.7 million people have received their 2 doses, and up to 39,000 people have had doses distributed. And they are mostly getting the Biotechnic and the Moderna vaccines. Europe has bought 2.3 billion doses, and so they bought it from a wide range of sources and developers, and so we should expect their vaccine protocol to be implemented soon as possible. So just one thing to say is that COVID-19 has traits that are not yet fully understood. Viruses mutate, and so herd immunity may not be possible. We have an unknown durability of protection. We can get poor immune responses in the elderly, and of course, there are some vaccines that need to be approved. In terms of vaccination across the Caribbean, the one thing I would say is that 2017 marked 40 years since the Pan American Health Organization started the expanded program of immunization, and that has led to the elimination of poliomyelitis, measles, rubella in the English and Dutch-speaking Caribbean. And this was in part, if you look at this slide, since the 1980s to 2015, as you increase the number of percentage vaccinated, there was an increase in the campaigns to get people to understand that these things are not that are serious, and vaccination does help. And most of us walk around now with a BCG scar, or remember getting their polio under their tongue, polio vaccine under their tongue as a teenager, etc. We all lined up to get this because, of course, it was important not to get polio. I'll skip that sky. These 2 slides. Talk about the action plan for the new SARS covariants, and of course there are multiple covariants circulating globally. I should tell you about 3. The new variant, they're called variants of concern, so the VOCs. So the new variant SARS, which is the B117. In South Africa, there's the B1351, and in Brazil, there's a new variant called P1, which has emerged. Now, what we know is that these viral properties could increase effective reproduction number in the population, and the R number is the number of secondary infections that can be produced by a single infected person. In case of the variant of concern in the UK, estimates suggest that the R number could increase to 1.4 with no change in population behavior. So once a more contagious variant has established itself, stabilizing the new infections will become increasingly difficult. So strain surveillance is an important aspect of public health strategy. The ability, we need to, because there's evidence of mutations, we need to be able to surveil quicker. There's also the impact that new variants can cause milder or more severe disease in adults, and it may evade some diagnostic tests. So specific tests may need to be put in place to pick up these variants. Next steps in terms of maintaining low numbers, we need to define targets and rekindle motivation. We have to go through the long haul. If you stay to the end, you might get a better outcome than if you give up early. Countries need to act early, reduce number of physical contacts, and prevent contagion by individual measures. Trace, isolate, and support, screen and test preventively, and increase genetic sequencing and PCR-based detection of not just the new variants, but variants that might arise in countries themselves. I suppose the important thing to say here is that we need to have a plan for vaccination within our nations. We need to have the supply chain, the logistic all sorted out on paper and ready to go. And we should be reactive to be able to modify these, because as we know, we're working with an unknown monster. Communication is the most important thing. And just the PAHO has the communications framework, communication, strengthen health systems, being intelligent about collecting data, putting in the public health measures and enabling functions. And I think I'll stop it there because I've got 40 minutes running into a 30-minute presentation. Thanks for your patience.
Thank you, Professor Anderson. Very grateful for your very in-depth presentation. I just wanted to stop at this moment and apologize for my audio in the initial beginning of the webinar. I'm hoping that things have somewhat improved. We do have a number of questions after the presentation, and I'm going to invite Dr. Blaze as well to rejoin us in terms of being available to answer some of the questions that we might have. The first question is coming from our YouTube platform. And the first question says that we understand that mRNA performs functions in the cytoplasm by producing a protein. Where does the DNA vaccine carry out its role? And is there any possibility of the DNA vaccine altering human DNA? So I'll pose this question to both Dr. Blades and Prof. Anderson, if available.
Well, what I'd say is that the RNA vaccines are really short-lived molecules which work outside the nucleus. So they're not working or being activated in the nucleus of the cell, but they're working in the cytoplasm where everything happens. And so and they're short-lived as well. So it's just the ability to allow the body to make the epitope or the area of interest so that the body can develop antibodies, etc. Whereas with typical situations, what happens with the previous vaccines is that we've just got the vaccines that have been inactivated, and therefore they're not able to spread once they're inactivated, of course. And so the body has to see all of the vaccine instead of the part that is most important. So those are the differences, I think, between the two. I don't know if Dr. Blades has something more robust to say about that.
Not really. I think that's correct. The older vaccines, I think the question was about the DNA. I'm not sure the DNA is, they're not supposed to make or go into the cells. They're just supposed to present, the vaccines present an area of the virus that we're trying to stimulate an immune response to. And then that happens at a cellular level. It does not go into the nucleus. It does not go into the cell as such. They're both short-lived. mRNA is more short-lived than DNA in terms of storage, but the body quickly expels them from the cells, and they're not supposed to live there or doing damage to the cell itself, as far as I'm aware.
And if I can just add as well, Dr. Bates, I believe the vaccine itself does not have any of the enzymes necessary to actually convert or actually cause mRNA to go to DNA and be incorporated into the actual nucleus. So it just has the code for mRNA for the spike protein, which then once in the cytoplasm creates the actual spike protein that we can be able to develop antibodies. But we would need to have enzymes such as reverse transcriptase, integrase enzymes, etc., in order to actually integrate that genetic material into our own genetic material. So I just wanted to add that bit as well, Dr. Bates.
None of the vaccines that we have now are actually DNA vaccines. So the two vaccines of interest at the present time are RNA vaccine. But I should say that there are about 8 of the 173 vaccines that are of DNA variety. We haven't seen, those are not yet been published, so we can't really say much about them in terms of efficacy, etc. So people should just remember that at the present time, we're talking about what's available and not what's on the fire, not what's not being cooked at present.
Thanks, Prof. One question for you as well, Prof. Anderson. Another person is raising on the YouTube platform. I think you touched it in your presentation as well, but just for emphasis, do you mind re-emphasizing if you've had COVID-19 before, should you get the vaccine is the question. I do believe there is some talk about possibly delaying for approximately 90 days after acute infection before you actually get the vaccine. Could you shed some light on that?
Yeah, the only thing I'll add to that is that, of course, there are vast amounts of people who had COVID-19 and did not know. And a vast amount of those people are going to get vaccines. Of course, ideally, it would be important to check an individual whether they're positive or negative at the time of vaccination, but that's not going to be possible. So we have to base that on symptoms, etc. So if someone comes asymptomatic for a vaccine, the assumption is going to be that they're not having COVID. And of course, they will get their vaccine in that situation. We'll see how it works out in the future in terms of the numbers. We just have to keep surveillance tight to see how effective things are.
Vaccine antibody levels. Sorry,
go ahead, Dr. Bates.
Yeah, the vaccine antibody levels wanes off after time, right? The IgG for sure. Sorry, the IgM for sure. The IgG stays a little longer. And sometimes you can do an antibody test to check the level of antibody. That may help, but I'm understanding though that even if you had the COVID virus, you should still get your vaccine because you don't know how long the vaccine will last. Something 90 days, something less. So it all depends on the length of immunity that it provides.
And you've kind of entered into the second question, or the other question I want to ask to both of you guys. Is there any evidence out there to suggest that the immune response from the COVID-19 vaccine is more efficacious in terms of neutralizing the virus compared to if someone would have had the vaccine before, would have had the infection before?
Some antibodies neutralize the spike protein, and there's not a theory of a push to that has not proven very effective, where you can use immune plasma from people who had the virus to transfuse those who are critically ill and not improving. But I'm not sure how much of that has been pushed there. When it first started in the US, there was this campaign to begging people who had COVID to give the donation, give the blood. But I think studies came after that saying it's not really that effective. And I'm not sure if it is being pushed anymore, but there are studies, even in the Caribbean, Jamaica, I think it is, that is looking at that issue of immune plasma and the fact that the antibodies will neutralize a part of the virus.
Okay, thank you for that, Dr. Blades. One question directly to you, Dr. Blades, was asked in the Zoom platform. Is it okay to say the difference between the Pfizer, Moderna, and AstraZeneca vaccines is the degree storage? And furthermore, why is the Pfizer vaccine chosen for Barbados?
Yeah, the storage is a big issue. The Pfizer and Moderna vaccine is still at minus 70. I said before that is because of the RNA is in the very label. I'm not sure why it's from Barbados. I know that the Caribbean countries had entered into a relationship where they were trying to procure vaccines so that it would be an equitable distribution. And I think the World Health leader talked about this moral decline in fact that some countries are able to buy vaccines at large quantities and at the disadvantage of other countries who can't buy. And this was supposed to be a COVAX facility where there was equitable distribution, where poor countries were able to get vaccine and not be disadvantaged because they didn't have money to buy. That's a big important issue. I'm not sure why Barbados is choosing the Pfizer vaccine, but perhaps I know that storage is the issue. And I saw in the paper today somebody talking about cold storage and so on. So I don't know the exact reasons why it's chosen. Perhaps it's a matter of cost. I don't know. Professor, do you know the cost difference? I thought you had a slide with that.
So I did have a slide with the costs. I didn't pay. I can tell you, but the Moderna vaccine is the most expensive. That's from recollection.
Right, and the AstraZeneca.
It's the Moderna is £25 or $33 and the Pfizer is £15 or $20. So it is cheaper, of course, and than the Moderna.
Thanks again. Prof, this question is to you. Would you be able to provide any insight on the mortality rate here in the Caribbean region compared to USA and EU? I did a presentation on local statistics from ICU, and I do believe that we've only had around 9 deaths, which puts us just around less than 1%. Prof, I'm not sure if you agree or will be able to provide statistics from other countries as well.
Yes, thanks for that question. The mortality rates are quite low in the Caribbean, and that was because we had effective NPI or non-pharmaceutical interventions in place. A lot of countries closed borders, etc. Thus far, in my slides, we actually count the number of deaths and cases per year, and I don't keep it fresh in my mind, but across the region, there are 1,500 deaths among 71,000 cases. So that's the case fatality rate there. So that is pretty low.
I add one thing, not about the deaths, but we miss the fact that there are so many recoveries, and that's
Absolutely.
a success story that we ought to jump. Success recoveries are big, and the more that Dr. Ford and colleague does to promote and safeguard recoveries is tremendous work. We ought to applaud them for that, and use that as an example of success and move forward.
Okay, I'm going to allow 2 more questions. I see Sandra Seeley is asking the question. I read in the London Times that the UK wants to immunize as many people as possible by giving the first dose to a large number of people and delaying the second dose. The claim is that the first dose has some preventative effect. 1, is this a good move? 2, is it true that the first dose can prevent some people from getting infected?
Right. So this is a difficult one in the sense that we when I say we, I mean clinicians tend to follow what the clinical trial has done. So the 3 clinical trials in relation to these vaccines have had an initial dose and then a dose given a specific number of days afterwards, and the regulatory bodies that considered these trials gave permission for those vaccines to go ahead in terms of large scale use based on those numbers. Now, what can happen from time to time, and I'm not saying that this is what should happen, but what can happen from time to time is that public health officials may make decisions on a public health basis rather than on an individual basis. And so it seems that the UK has taken the decision that if we want to get our everyone vaccinated, as most people vaccinated as possible, then we're going to utilize the idea that those who were vaccinated first dose had a various percentage of effectiveness, and of course the effectiveness didn't increase by that much more afterwards. That's so. I mean, that's one way of thinking about it. But I think that I would follow Fauci and the FDA in their consideration of this, where it is important to just stick to the. For me as a clinician, if I wanted the vaccine, or if I get the vaccine whenever it comes, I don't want to be outside of the range of what was tested. I want to be tested as it was tested in everybody else and how I got the vaccine. But that's a personal thing. Over time, people might change that, or we'll see the data to say that it made no difference, etc. That'd be interesting to know, as long as someone is looking at the outcomes and looking at the data to make sure that those people who've received one dose and haven't received the next one within the specified time are still remaining sort of safe and are not having higher risk of getting COVID. But it could cause problems in how people consider the vaccine and its uptake, and so I think that what will happen in Barbados is going to be under the auspices of what the Ministry of Health and its officials decide for the country, and so if another country does it, it doesn't necessarily mean that that's what would happen here. It just means that if you are living in England at this present time, or in the UK, then that's the situation that you'll have to work under.
I agree 100%. Thank you, Prof. I do believe on reviewing the article, it was just around after the first dose, 56% persons or 56% response in terms of antibodies, and just after the second dose is around 94 to 95%, and just around 7 days after they reached the maximum in response to the vaccine. So I agree with you 100%, Professor Anson, that we must indeed follow the science. I'm going to allow 2 more questions before we go to Pastor Peters. These questions are, can you take the vaccine if you have high blood pressure? And what does it mean for persons who can have an allergic reaction to the vaccine? If I can start, Dr. Blaze, you want to respond?
Go ahead. I can react.
No, I was just about to say that from the clinical trial, they did report in terms of the participants and the demographics of the participants that the persons did have the usual chronic non-communicable diseases, high blood pressure, diabetes. Some were even immunosuppressed as well. So in terms of the demographics of the patients, these persons did have high blood pressure. And it has been shown to still be safe and efficacious in these individuals who have these chronic non-communicable diseases. Dr. Blaze, you want to add?
Listen, with the allergies, they're saying that if you have allergies, you should be cautious enough to report them if you have any reaction to the vaccine, because they've seen that some people have adverse allergic reactions, which should not be ignored. So if you have allergies, if you're predisposed to allergies, then you should monitor yourself and report any serious allergic reactions to the authorities. Yes.
Yes, definitely. So we did know about the case in the UK of a emergency room nurse, I believe, or physician that had severe allergic reaction to the vaccine, and since then the guidance has suggested that if you do have a known allergy to the vaccine, you should indeed report this to your physician prior to taking the vaccine. Um, so I think that's all the time that we have for questions. Again, I want to reiterate that you can still post the questions in the group, and we would allow for Professor Anderson and Dr. Blaze to respond to them if time permits. But we are going to go ahead to the last presentation, which will be given by Pastor Jason Peters. Just a little bit about Pastor Peters. He was born in the island of Dominica. In his 22-year tenure, he served as the East Caribbean Conference of Seventh-day Adventists. Served the East Caribbean Conference of Seventh-day Adventists as a teacher, pastor, and youth director. He started denominational work in 1993 as a teacher at our secondary school in Dominica, where he served for 3 years. He later served at the Barbados SDA Secondary School for 2 years, and he taught in the subject areas of science, geography, and mathematics. As a pastor, he served the districts of Silver Hill, Ephesus Gardens, and St. Peter in Barbados. In 2013, he was elected to serve the East Caribbean Conference as the youth director. His ministry took scores of young people traveling and ministering in missionary ventures around the world, including Guatemala, St. Lucia, Martinique, Grenada, British Virgin Islands, and Trinidad and Tobago, to mention a few. Pastor Jason Peter loves pastoral ministry, as you'll be privy to see, and looks forward to every opportunity to serve God and his people. His passion to see the youth excel and grow in their walk with God has led him to design the Sanctuary and Righteousness by Faith series, which has special emphasis for the youth audience. So today, Pastor Peters will speak on the topic of COVID-19 and spirit of prophecy, as we have realized that many persons have had concerns about the vaccine as it relates to numerous things, inclusive of the mark of the beast, etc. I thought it quite fitting, given that we are speaking to a church audience and by extension other professions as well, to offer as a closing this talk on COVID-19 spirit of prophecy. So without any further ado, please let me welcome Pastor Jason Peters to speak to us at this time.
Thank you, Doc. It's a privilege to be with you this afternoon. I want to thank Dr. Bentley and the others, the organizers, for having me as part of this. I believe it's an interesting segment to add to this discussion, to look at biblical, spiritual, or prophetic aspect of what we are currently going through. So this afternoon, I want to encourage us to, as we listen, please, as you've been doing, listen with keen mind, that God would guide us to make intelligent decisions as it relates to this matter. To set the platform, the foundation to what I would like to share with us this afternoon, I want to look at 3 passages of scriptures. The first one comes from Revelation chapter 12, verse 7. Revelation chapter 12, verse 7. The Bible says, "And there was war in heaven. Michael and his angels fought against the dragon, and the dragon fought and his angels." The second passage of scripture that I'd like to share is John chapter 10 and verse 10. John chapter 10, verse 10, which says, "The thief comes not, but for to steal, to kill, and to destroy." Jesus says, "But I am come that you might have life, and that you might have it more abundantly." And the third passage of scripture comes from 1 Peter chapter 5, verse 8. "Be sober, be vigilant, because your adversary, the devil, as a roaring lion, walks about, seeking whom he may devour." These 3 passages of scriptures, Revelation chapter 12, verse 7, which talks about the war in heaven, John chapter 10, verse 10, where Jesus describes the devil as a thief who comes to steal, kill, and destroy, and 1 Peter 5, 8, where Peter writes about the devil as our adversary, as a roaring lion seeking whom he may devour. These three passages of scriptures help us to form the framework for what is referred to by Bible students as the Great Controversy theme. I am not talking about the Great Controversy book. I'm talking about the theme that runs throughout scripture, the Great Controversy theme. These three passages of scriptures help us to understand the reason why we are in this situation we are in today, and not just today, but from the very beginning of man's existence. This concept of the Great Controversy theme, this concept reveals a spiritual warfare between Jehovah, who is the creator of heaven and earth, and Satan, who is the adversary of mankind. So there's a spiritual battle, a warfare that is going on in this universe. And this spiritual warfare, referred to as the Great Controversy between God and Satan, is a consistent and persistent theme in the writings of Ellen G. White. Now, I've been asked to speak on the subject matter of COVID-19 and the spirit of prophecy. This can be looked at as saying, let's look at the situation of COVID-19 and what the Bible has to say on it. What does our spirituality have to do with this? What does our religion or denominational beliefs have to do with this? For us as Seventh-day Adventists, in a more specific way, we are looking at what we refer to as the writings of Ellen G. White. So even if you're not a Seventh-day Adventist, the principles, the information that is going to be shared here falls right into your realm of spirituality, whatever your beliefs may be. So the objective for me this afternoon would basically be to present a prophetic context, to present a biblical and prophetic context for the COVID-19 disease as it relates to the writings of Ellen G. White. So let's jump right in. It is important to note that the Great Controversy theme that we spoke about, we've established with the three passages of scriptures that we've read. It is important to note that the Great Controversy theme forms the backdrop and creates the framework for the sin problem that humanity finds itself in. Whether you're a Christian, whether you're a member of any other religion, whether you're non-religious, whether you're an atheist, you look around you and you realize that humanity has a problem that humanity itself cannot fix. From a Christian perspective, that problem is described within the Bible as it relates to the Great Controversy theme, a battle between good and evil, a battle between the Creator, Jehovah, the Creator of heaven and earth, and the adversary, the devil, who is seeking to destroy mankind. For a beautiful write-up on the Great Controversy theme, because we are looking at the Great Controversy theme from the perspective of the spirit of prophecy or the writings of Ellen G. White, I want to recommend to our listeners this afternoon, in your own time, read the first 4 chapters of the book, The Story of Redemption, written by Ellen G. White. The book, The Story of Redemption, the first 4 chapters of that book sets up for us, including in what Genesis chapters 1, 2, and 3, the first 3 chapters of the book of Genesis, the first book of the Bible. Those 4 chapters of the story of redemption help create a beautiful backdrop to help us understand what that Great Controversy theme is all about, and the extent to which the devil has gone to misrepresent God and to destroy everything that God has created for the joy of mankind. Now, an interesting element in the writings as it relates to the Great Controversy theme, I'm talking about the writings of Ellen G. White. An interesting element in the writings of Ellen G. White as it relates to the Great Controversy theme is the fact that as humans, and not just within her writing, within the Bible itself, I should say, that great controversy theme that is present in the Bible and in the writings of Ellen G. White, a very interesting element to that fact, to that controversy, that great controversy theme, is the fact that as human beings, we have found ourselves in the middle of this conflict. Not just being found in the middle of this conflict, but no human being is left standing on the sidelines or in the middle of the road. Every human being has to choose a side. There is no demilitarized zone when it comes to the great controversy conflict that the human race has found itself in. And so I want to share with us, I'm going to share with us a number of quotations from the writings of Ellen G. White, which are being referred to as the spirit of prophecy. I'm going to share a few quotations from those writings to help us to see and to understand where this COVID-19 falls into that, and how we can make some intelligent decisions as it relates to that. As the doctor said during the introduction, we have heard a lot of things concerning COVID-19 and spirituality, COVID-19 and the Bible, COVID-19 and prophecy. And I believe as Bible students, whether we are Seventh-day Adventists or any other Christian denomination we find ourselves in today, we are to make intelligent decisions, not just make intelligent decisions, but we are to speak with intelligence as it relates to biblical subjects. And so Sister White, Ellen G. White, has given a number of important guidelines and information as it relates to what we are actually going through. And I would like to share some of these with us this afternoon. The very first quotation that I want to share with us, I want to read this in your hearing. I want to read this in your hearing. It says, there are many, and we're talking about this quotation that I'm going to share is to help us understand that no one is to stand on the sidelines as it relates to the great controversy theme. We are all part of this. So here goes the quotation. There are many who do not understand the conflict that is going on between Christ and Satan over the souls of men. They do not realize that if they would stand under the bloodstained banner of Prince Emmanuel, they must be willing to be partakers of his conflict and wage a determined war against the power of darkness. So every Christian, every person within this human race finds himself in this great controversy theme, and every Christian, by accepting Jesus Christ as Savior, by accepting God, by being in relationship with God, automatically you're saying that you are on the side of light and you're going to fight against the powers of darkness. And that fight against the powers of darkness is not just by our words, but by our very lifestyle, everything that we do. I'm laying the foundation to what we want to the heart of the presentation. According to the scriptures, it is becoming evident that we are nearing the culmination of Earth's history. What is also noteworthy is the fact that both Christians and non-Christians alike have begun to voice the idea of an impending doom that is soon to come upon the human race. And so we have on an international platform, we had the Left Behind series that talked about the rapture that is going to take place. Of course, not every Christian believes in the secret rapture, but the principle of the movie is this, that something is going to happen on a global scale. That's within the religious realm. And every preacher, if you just go on YouTube, if you turn on Zoom, every preacher is talking about the same thing. Something is about to happen. We have secular movies like 2012, which presents a global catastrophic event that has the potential to wipe out the human race and to wipe out civilization as we know it. So both from a religious point of view and even from a secular background, we are getting the same themes being presented to us over and over again. So there has been, when we pay attention to this and then look at it from a medical and scientific point of view, we cannot deny that there has been a steady increase in both natural disasters and maladies and sicknesses and diseases over the last 50 years or so, with a rapid increase. While it may be beyond human knowledge to understand the precise cause of these diseases, for the Bible believer and from a biblical perspective, however, some things are certain. And as Christians, we know that Satan is the one who seeks to destroy as many people as he can, and he will use every means that is available to him. What I want to do at this time is share with us some extracts from the writings of Sister White as it relates to end-time catastrophic events and where the blame should be placed. And I'm going to share this to help us to put together a framework as it relates to where COVID-19 lies and what decisions we are to make as it relates to this. So the first quotation comes from the Review and Herald, Publishing Association. It was published in 1980, volume 7, page 967. Washington, D.C. Review and Herald, published in 1980, volume 7, page 967. It says, and it says, angels are belting the world, surrounding the world. And this is the idea that we get from both Revelation 7 and Revelation 14. Angels are belting the world around, refusing Satan his claims to supremacy, made because of the vast multitude of his adherents. We hear not the voices, we see not the natural sight, the work of these angels, but their hands are linked about the world, and with sleepless vigilance, they are keeping the enemies, or the armies rather, they are keeping the armies of Satan at bay till the sealing of God's people shall be accomplished. What is being said here? The Bible gives us the idea that the devil wants to unleash his fury upon the world. Both Revelation 7 and Revelation 14 give us the idea that God has stationed mighty angels to hold back the wind of strife. And Sister White is writing here, and she's saying to us that the devil is doing everything to unleash his fury upon the world, but he is being kept back. He is being kept in check. He is being kept at bay. The second quotation that I want to share with us comes from Washington, D.C. Review and Herald, Publishing Association, book number 2, page 51. That's just in case you want to write the references and check it up for yourself. This is what the quotation says. Satan is working in the atmosphere. Listen to what she says. Listen to what is written there. Satan is working in the atmosphere. He is poisoning the atmosphere. And here we are dependent upon God for our lives. Here in this world, we are dependent upon God for our lives, our present life, and our eternal life. And being in the position that we are, we need to be wide awake, wholly devoted, wholly converted, wholly consecrated to God. But we seem to sit as though we were paralyzed. God of heaven, wake us up. Wake us up to what? To the reality of what is happening in an unseen world. The things that we see before us are not, that's not all there is to reality. There is an unseen reality, and the Bible, both the Bible and the writings are saying to us, the one who is behind this unseen reality is the devil himself. And she begins this statement by saying, Satan is working in the atmosphere and poisoning the atmosphere. I love this next quotation where she says, where she puts it this way. And when I read this, it blew my mind many years ago. And this comes from the book, The Great Controversy, page 589. The Great Controversy, page 589. And this is what is written there. Satan works through the elements also to garner in his harvest of unprepared souls. What elements she's talking about? The natural elements, the natural world. He works through the elements, he works through the natural world to garner his harvest of unprepared souls. Listen to this. He has studied the secrets of the laboratories of nature. He has studied the secrets of the laboratories of nature. And so when we hear our scientists are saying to us they don't understand where these viruses come from, as Christians, we are to be wise enough to understand that there is another enemy. There is an enemy of souls who understand the secrets of the laboratories of nature, and he uses all his powers to control the elements as far as God will allow. He will bring diseases, listen to this. He will bring diseases, disasters, until populous cities are reduced to ruins and desolations. Just think of the number of natural elements, natural disasters by land and sea and air, the things that are happening around us. When we talk about climate change, all those things, as Christians, these things are not political agendas. As Christians, we should have a knowledge of all those things that God has already said to us would be happening. So let's listen to this. He will bring disease, disasters, until populous cities or populated cities are reduced to ruin and desolation. Even now, he is at work. In accidents and calamities by sea and by land and in the air, great fires, in fierce tornadoes, and terrific hailstorms, in tempests, floods, cyclones, that's hurricanes, tidal waves, earthquakes, in every place and in 1,000 forms. Satan is exercising his power. He sweeps away the ripening harvest, and famine and distress will follow. He impacts to the air deadly taints, and thousands perish by the pestilence. These visitations are to become more and more frequent and disastrous. Destructions will be upon both man and beast. Taken from the Great Controversy, page 589. This is to give us a context. It's from a spiritual point of view. This should lead us from the political agendas that some of us are running with, and from the misguided statements that many of us are making. I have been shown, let me give the reference first. Last Day Events, page 27. Last Day Events, page 27. I have been shown that the Spirit of the Lord, now look at how the context is shifting here. Remember, from Revelation 7 and 14, we are given the idea that God has stationed mighty angels to hold back the devil from unleashing his fury on the earth. Because Peter tells us the devil is like a roaring lion, and he's seeking whom he may devour. So the devil wants to destroy. Jesus says in John 10:10, he has come to destroy, to steal, and to kill. I'm trying not to preach. And that this is what he wants to do. But a time will come when all that protective shield that God has placed on man is going to be withdrawn. The Bible says the Spirit of God will not always strive with man. And so from Last Day Event, page 27, this is what it says. I have been shown that the Spirit of the Lord is being withdrawn from the earth. God's keeping power will soon be refused to all who continue to disregard his commandments. Iniquity will become so common a thing that it's no longer shock. It no longer shocks the senses as it once did. We will hear of crime and violence, debauchery. We will hear of all the worst kind of wickedness, and it will not matter to many because we've been desensitized. And the final statement that I want to share from the writings is this: when God's restraining hand This comes from the great Last Day Events as well, page 111. Last Day Events, page 111. And this is the last quotation from the writings that I want to share, where she writes, when God's restraining hand is removed, the destroyer, who is the devil, begins his work. And from the things that we are seeing around us, it is evident that God is beginning to let loose. And we have been told that what we are now seeing is just the tip of the iceberg. From a spiritual point of view, I'm no medical professional, but I'm sharing this from a religious, spiritual, biblical, prophetic point of view. Now, having said this, I want for the next few minutes to share with us a statement that was given by the General Conference as it relates to COVID-19 and the vaccine. The reference is the General Conference Department of Health Ministries, General Conference Biblical Research Institute, in collaboration with Loma Linda University School of Pharmacy, School of Public Health. Of course, I'm not going to read the entire thing. It's on the internet if anybody wants to check it out. So the next few things I'm going to say are direct quotations from that document. There are rumors, the document says, concerning conspiracy theories that use the COVID-19 vaccine as an interpretation and a fulfillment of prophecy. So there are many Seventh-day Adventists who are going crazy, who are going wild all over the internet, prominent preachers who are talking about the COVID-19 and the COVID-19 vaccine in particular as a fulfillment of Bible prophecy as it relates to the mark of the beast and all of that. One of the views is that the vaccine produced to combat the COVID-19 disease belongs to a process of control that will lead the application to the mark of the beast. What they're saying is this: many among us, I should say, are saying that the COVID-19 vaccine is what the Bible refers to as the mark of the beast. And if anybody receives the vaccine, they are receiving the mark of the beast. Now, having read this and having listened to a number of persons, both spiritual leaders, theologians, and laypersons on the matter of COVID-19 and the mark of the beast, this is what I now want to share in relation to that. From a biblical and prophetic point of view, so I'm sharing this here from a biblical and a prophetic point of view. If you are a Bible student, if you've studied prophecy, if you've read the prophecies of the Bible, Daniel, Revelation, Matthew, and all that Jesus has said in relation to end-time prophecies and the end-time sequence of events as they're going to happen, I want to share with you about 3 or 4 main points. Point number 1, the end-time controversy concerning the mark of the beast will be centered on the law of God, and particularly as it relates to Sabbath, the Sabbath commandment. This is clear from the Bible. Revelation chapter 13, Revelation chapter 12, Revelation chapter 7, Revelation chapter 14. The end-time controversy that mankind is going to find himself in as a believer in God relates to the law of God and obedience to God and worship, the worship of God, or refusal to worship God. Point number 2, the third angel's message. The third angel's message will warn against the reception of the mark of the beast, and we find this in Revelation chapter 14. The third angel's message will warn against the reception of the mark of the beast. And that third angel's message will enlighten mankind as to the issue involved in the mark of the beast. So if you want to understand what the mark of the beast is about, Revelation chapter 14 is the chapter to read on that, and Revelation chapter 13, of course. The next point is this: the mark of the beast is not a literal mark, but a sign of allegiance that identifies the bearer as a loyal person to the powers that represents the beast. It is not a literal thing that you can see. And by the way, no one can give you, no other human being can give you the mark of the beast. No other human being can give you the mark of the beast. The mark of the beast will be received. Pay attention to this here. The mark of the beast will be received by all those who reject the gospel of Jesus Christ. The mark of the beast will be received by those who reject the gospel of Jesus Christ. So the mark of the beast relates to worship of God or the rejection of Jesus Christ and the gospel of Jesus Christ. So in summation of this, let me put it this way. The gospel of Jesus Christ would be preached in all the world for a witness. That's what Jesus says. This gospel of the kingdom will be preached in all the world for a witness. When the gospel of Jesus Christ is preached in all the world, the saints of God who have accepted the gospel of Jesus Christ will be sealed. All those who then rejected the gospel will then receive the mark of the beast. So the mark of the beast will only be given after probation comes to an end. It means if the COVID-19 vaccine is the mark of the beast, it means that probation has already ended. Are we together? It means probation has already ended. Now, these statements are not presented to tell the listener that the vaccine is safe or unsafe. That's the role of the medical persons who did a fantastic job. These statements are designed to put into prophetic perspective that the COVID-19 or the COVID-19 vaccine in particular are not the mark of the beast as spoken of in the Bible or in the book of Revelation. I want to thank you for listening to me. I pray that God would bless us and his Holy Spirit will continue to guide us as we make wise and intelligent choices. God bless you.
Thank you very much, Pastor Peters, for elucidating on the topic of whether or not COVID-19 vaccine is related to the mark of the beast. I was up on at work at the time, and there was even a young lady commenting on that. I overheard her talking to a friend that, COVID-19 vaccine is the mark of the beast. So I thought it was very fitting to have yourself, a pastor I truly respect, for the ability to expound on information, to expound to the audience or the participants here on such a very important topic. And I thank you so much for doing an excellent job, Pastor Peters. Thank you so much. I want to take this opportunity now, it's 5:30, to have an extended session, Q&A session, for those questions that were not answered previously. So I want to invite Dr. Blades and Prof. Anderson to engage in this Q&A session, which is our final Q&A session, as we do have a few questions that are still outstanding to be addressed. The first question that I'm going to ask the panel, one of the persons asked if they do receive the vaccine, if they still have to wear a mask. So I'm going to pose that one to Prof. Anderson to comment on public health policies.
Thank you. So that's, of course, the assumption is that that person makes is that having taken the vaccine, they're 100% protected. But as we mentioned before, that the vaccine only has efficacy up to 95, 96%, or even lower if you consider the Oxford vaccine. Therefore, the other thing that we mentioned throughout was that we don't know in terms of the vaccine how long its efficacy will last. So, for example, if you had the mumps and the rubella as a child, it protects you now, but we don't know that for the vaccines that are in development, because they've not been around long enough for us to have any judgment as to how long it causes protection. Therefore, it would be useful for everyone to follow the guidelines according to public health measures, including covering your face with a mask, washing your hands, or using appropriate sanitizers, to physically social distance, etc. Because we cannot tell that you will be one of the 5% or you will be one of the 95%. So from my perspective, and it also helps the rest of society to stand in line as well. Thank you.
Yes, the idea of mask wearing is to give other people the confidence that, you know, you can have some people wearing and some not wearing. Then that engenders a disrespect, if you want to say, of not wearing a mask. And the people will watch you and say, hey, he ain't wearing none, so why should I? So I think that apart from the science, that we should still wear the mask to give collective responsibility and confidence to everybody and wear the mask, as well as the fact that the mask protects you as well from other people, not only them from you. So it goes both ways, and yes, you should still wear the mask.
Okay, thank you very much. And this is definitely borne out in the clinical trials and the evidence that it is still important to engage in these policies to prevent transmission. As the vaccine, when you look about the primary endpoints of the trial, it looked at preventing persons from having infection with the SARS-CoV-2. But when we talk about in terms of transmission, we still made mention of actually still engaging in these practices to ensure that we stop transmission amongst the individuals. So that's definitely something that has to go hand in hand in order to curb the spread of the coronavirus. We have some other questions as well. And someone asked, will the vaccine be made mandatory? And I do believe that CDC and the other regulatory bodies talk about the fact that the vaccine, or no one has stipulated that it is mandatory, and neither has anyone stipulated that it is needed for travel as well. I believe that this would be something that it will be implemented on a country basis. Unlike most vaccines, I believe, I don't know, I can't speak to policy here in Barbados, but if it is implemented, the vaccine is rolled out here in Barbados, I do believe that, like most other vaccines, persons can provide an affidavit from a medical practitioner if they wish, for whatever medical reasons, not to receive the vaccine. So this is all speaking ahead of time, but from what is out there right now, no one has mandated the vaccine, neither is it mandatory for travel. And this will be something that will be done on a country basis in terms of their regulations. But that means of affidavit from a medical practitioner still will hold presumably for this vaccine as well. Any other comments from the panel?
I agree with that. There's no mandatory edict so far. I've heard talk about airlines, requesting it, but not mandating it. And as the process evolves, you never know what happens. As you said, some vaccines are necessary for schools to protect others. And if you have a situation where there's not enough herd immunity, then those who are not vaccinated will, I don't want to say a threat to, but, if we have enough coverage, then I don't think it's necessary. But as you said, that there's not an edict from anybody so far.
All right. So thanks again to all the presenters, Prof. Anderson, Dr. Edward Bayes, Pastor Jason Peters, for your contribution thus far. I do believe, I think I see one more questions. Some are concerned about nanoparticles in the vaccine. Any thoughts on the nanoparticles? Does that pose a threat to anyone's individual health?
Prophet going first on that one. The
You can go ahead with that.
The nanoparticle is just the vehicle for delivering the protein from the vaccine. It is a wax lipid fat molecule. We all have that in our systems, fat and molecule and lipids. So it's not a threat to anything. It's just that they are housed in this little nanoparticle so that they can be delivered to the cell. It's very microscopic and it's not a threat to any of the systems. It's not a protein. So there's no issue with that. It's just the delivery vehicle that the vaccine manufacturers use to get the particles of the vaccine right to the cells. I don't see it as a threat. No.
Okay, thank you very much.
I have uploaded the presentation to those who wanted it.
Thank you for that as well, Pastor Peters.
Okay.
I don't believe if there are any other questions. There's one here as well. If the mRNA is code, who owns the copyright to that software? Not sure, Dr. Biz, if you can touch base on that. I don't know if there's anyone that holds copyright to that.
I don't have any information on that. Sorry. But somebody has it. They're big companies, and I don't know. That's another story.
Okay. Well, what I would do at this time, thanks to you guys again. I would, if you guys can permit me, I would seek to just do a quick summary of the salient points that were expressed in this webinar. Basically, the COVID-19 pandemic has led to over 2 million deaths worldwide. And as mentioned before, good public health policies coupled with the implementation of the COVID-19 vaccine is important to reducing transmission and infection of COVID-19 with possible deaths and poor outcomes as something we want to avoid. There are 3 options for the COVID-19 vaccine currently, while others are being worked on, and that was mentioned in the presentation by Prof. Anderson, AstraZeneca, Moderna, and Pfizer. And we know that this utilizes an mRNA technology, which, as was described in presentation, codes that spike protein, which is very, very important for the virus to attach onto the cell and gain entry to bring about its effect. So the mRNA, so it does not contain, and it's one important point to stress on, it does not contain a live or attenuated virus. It actually contains the mRNA sequence which codes for that spike protein. It enters the cytoplasm, which is also an important point to note as well, and it produces the proteins that will then act as the antigen for the body to mount an immune response. So it does not enter the nucleus of the cell where the DNA information is stored. Neither does the vaccine itself has the capacity to alter the individual's genome or DNA sequence. So that's also a very important point to make as well. It's found to be 95% efficacious, as was highlighted as well, and it's delivered as 2 doses, 21 days apart, and it's been shown to be 52% effective after the first dose, and it reaches up to 91% within the first 7 days of receiving that second dose. And then it reaches a full 95 to 96% efficacy by 7 days after the second dose. People have been asking as well what are the most common side effects? Well, pain to the area, usually 1 to 2 days after. You can have some systemic symptoms of fever and headache, and these usually resolve thereafter. Persons have been also concerned as well about the possibility of vaccine-associated deaths, and there have been no vaccine-associated deaths that has been borne out of the clinical trials. So overall, the vaccine is reported to be safe, it's reported to be efficacious, and it's been essentially reported to have relatively low side effect profile, lending therefore to its safety in persons at least 16 years and over, which represents the demographics that were used in the trial. So there are still some more information to be gleaned about whether it is efficacious or useful in persons less than the age of 16 and over the age of 55. And those trials and research events will still continue to be done. So this is the overall overview or summary of the salient points we want to bring home to you in this webinar. And I am very grateful for all the participants who have come as part of this webinar to gain information, ask your questions, get your myths addressed, and I'm 100% happy for the overwhelming turnout and participation by yourself, and I thank as well the presenters who are here. I want to take this opportunity to introduce and welcome Pastor Anthony Hoyt, who is the district pastor, to just give some closing remarks at this time as we close off. Pastor Hoyt.
Thank you, Dr. Bentley Young. It certainly has been a pleasure. North Central District, by extension. And of course, as I look through the chats on YouTube and also the Zoom platform, I believe that I should take the opportunity on behalf of the entire Seventh-day Adventist community here in Barbados to thank Dr. Edmund Blaze, whom I've known for quite some time when I pastored the Six Rose Seventh-day Adventist Church. He is still an elder there and one who could be depended much upon. Dr. Blaze, we want to thank you for sharing the wealth of knowledge with us, and you have certainly brought some clear understanding to this subject today. We also want to thank Professor Simon Anderson. What a privilege it has been to have you with us, to be able to sit at your feet. I'm sure, as some of the questioners have indicated, you know, there's so many things being tossed around out there about COVID-19 and the COVID-19 vaccine. And I believe that you have been instrumental in helping to bring a bit of some clarity to us here in Barbados. I certainly hope and believe that it would be of tremendous help. So once again, I want to say thanks to Professor Anderson, Dr. Young, who is our Health and Temperance Director at Ebenezer. Of course, this program would not have been possible without your efforts and your hard work. And I want to single you out this evening and say a very special word of thanks to you on behalf of the Ebenezer Church. And of course, behind the scenes, you could not see them, but the technical team did a fantastic job this evening, managing the platform, making sure that the questions were answered and so on. We say thanks to the team. And finally, to you, our attentive audience, of course, putting on a program like this and not having an audience to share it with would have been to no avail. So we want to say thanks to our audience as well for being there. I discovered that whilst the program was going, the chats were going, people were sending information out like wildfire, saying that the program is on right now. Some people were asking what program, but of course they got on in time, and I believe that you were all blessed. So to all of you, again, I say a very special thank you.
Thank you very much, Pastor Hoyt. And with that, I want to say that we've come to the end of our webinar. And like Pastor Hoyt, I want to echo his sentiments and thank everyone for participating. And I do hope that this information would have been useful and helpful to you in any way. So thanks once again, and do have a wonderful evening. Thank you.